We shall now go on to our next speaker, Dr. Madhu Shekhar. He was the chief of the intraocular lens and cataract services at Arvind Eye Care, Arvind Eye Hospitals, Madurai, who's going to show us how to bail out a difficult moment. We look forward to hear you, Dr. Madhu.
Good afternoon, everyone. Thank you, AIOS-ARC and Dr. Chitraramurthy Madam for giving me opportunity. So I will share my video, Madam. So I'm going to present surgical management of a case with bilateral coloboma using phacoemulsification in one eye and manual SICS in other eye. And my patient is a 39-year-old young lady with bilateral chorioretinal coloboma and lens coloboma and nuclear sclerosis of grade 3 to 4. So first eye I planned with phacoemulsification and placement of acrylic IOL. So rhexis was intact, but it was slightly eccentric near colomatous area. You can see that during hydrodissection, there was a split in the colomatous area, but I thought I will proceed with phacoemulsification. First chop was attempted, but during second chop, it started tilting. So I put dispersive viscoelastic and retrieved the nucleus in the anterior chamber with the help of Sinski hook. And then I plan to convert it into a manual small incision cataract surgery. I shifted my site from temporal to superior side. Sclerocorneal tunnel was fastened. I was in early stage of phaco, so I decided to convert it into SICS. Nucleus was extracted out with the help of irrigating practice. Automated vitrectomy was done, and then I used Simpo cannula using dry aspiration to not to hydrate vitreous much. After aspirating all cortex, I placed 3-piece acrylic IOL in the sulcus and centered it. The second eye of same patient, that there was nucleus sclerosis of grade 3 to 4, and lens coloboma was slightly larger. So I planned for manual small incision cataract surgery instead of because in first case there was nucleus was about to drop. So I planned for small incision cataract surgery. In this eye also, I was careful during capsulorhexis because there was a split in capsulorhexis in the first case. So I was doing capsulorhexis at utmost care at the area of coloboma. I completed the rhexis. It was a continuous capsulorhexis. I tried to make a slightly larger capsulorhexis in the area away from the colobomatous area so that I can prolapse out the hard nucleus. Then very gentle hydrodissection was performed. And then I used a bimanual technique to prolapse out the nucleus out of that and to relieve the stress on the capsule. Then I extracted the nucleus out with the use of irrigating practice. But in this case also, after removal of nucleus, I saw there was a split in capsule near the colobomatous area. After cortex aspiration, 3-piece acrylic IOL was placed in the sulcus and case was closed. So in both the cases, actually the rhexis was complete, but it is split off near the colomatous area with minimal amount of force. So take home message will be from my side that we should be make rhexis smaller in the area of coloboma and slightly larger in away from the area of coloboma, and any maneuver should be gentle and always ready for managing this type of complication with 3-piece IU. Thank you.
That was a wonderful learning, and it's always safe to convert if in doubt. But these were my thoughts. I think most importantly, we should create a smaller rhexis well away from the area of the colobomatous area. And if the flap, you look at the flap eversion and inversion sign, which Dr. Rohit Om Prakash tells, which makes so much sense. And unless the nucleus is tilting, I don't see any reason that we need to convert it into an SICS. We could go ahead and complete it. But in any of these eyes, one question which I have to all of you is, would you believe, keeping in view that there could be a zonular weakness in that colobomatous area, would it make sense to use a CTR? Because I do understand that these are eyes again, which can have a fluid misdirection. So if you place your CTR beforehand itself and go on with the surgery, that is one preventive measure. And does it at all make sense to do a pupilloplasty in these eyes? Dr. Namrata?
So I think I wanted to ask Dr. Madhu one question, and regarding the CTR, I don't routinely put CTR in all these cases of coloboma, but I don't know if there are other studies and if others do so. Having said this, Dr. Madhu converted in the first eye, and then in the fellow eye planned SICS. I think I
Yes,
would have
madam.
started again with phaco only in the fellow eye.
No, I started with SICS only, madam, because nucleus grade was slightly harder in this eye, and there was a larger colobomatous area in the inferior side.
Okay.
Anybody's thoughts on whether it could have done a
Yeah,
favor?
Chitra.
Yeah. You managed very well. I mean, and you did.
Debashish?
Yeah. No, it's,
Yes.
I was trying to make a point that in the colobomatous eyes, the capsule is always weak. Even capsular hooks give away. Nothing really works. So I would go with Madhu with his experience in the first eye. He did a SICS in the second eye was perfectly justified, because in the capsular strength that this um, lens had, it would be very appropriate not to try anything, because you recommended a small capsular rhexis,
Yes.
all to use maybe a capsular hook if it gives away, but most commonly the capsular hooks give away in the colobomatous eyes where the capsules are weak actually. So I would go totally with Madhu. What he did was absolutely right and well done. The other thing, probably, if you are too adventurous on phaco, these cases also have a zonular weakness, and probably you do a pars plana vitrectomy and then go ahead with the cataract. That is a different scenario altogether.
I'd like to slightly differ from what was, in the sense that I think Madhu has done what worked best in his hands, and obviously the ultimate outcome is what matters. But in these cases of congenital coloboma, it's only in the area of the coloboma that the zonules are weak and are absent. And it's rest of them, you said 37, 38-year-old. Obviously, even the way you got the rhexis, it appeared that the zonular support is quite adequate. And it was just a coincidence that in both these cases, you had a rhexis runoff and a wraparound, and you ended up with in the first case, with a vitrectomy being required. But I have done quite a few, and usually do a phacoemulsification, and just making sure that the capsular rhexis is well away, the margin of the capsular rhexis is well away from the area of the coloboma. I do not believe that these capsules are any more weaker, or even the zonules are, the strength of the support for the lens is any weaker, because except in the area of the zonular weakness, the rest of the area zonules are intact. And normally we can go ahead and do a conventional phacoemulsification, of course, being exercising a little extra care. And there have been occasions when there have been extreme colobomas where the entire pupil is drawn to one direction. In those cases, that's just a tip, not relevant to this case. I just enlarge the pupil a little more because you want the optic of the lens to be seen through the pupil that is there, because some of these pupils are a little drawn to one direction. But otherwise, I think phaco usually works well in these cases. You had this problem more because the wraparound of the rexis tear that occurred rather than the problem of the coloboma being there.
There's also this logic about placing a CTR, not just for the weakness alone. It actually, these are the eyes where there could be a fluid misdirection. So placing a CTR beforehand after creating the rexis is one preventive measure, which has to be kept in mind.
No,
Yes,
but
I agree with
Chitra, there are many studies and literature to support that you know, people have placed CTR in these eyes. And another thing is that you should always operate these cases earlier rather than later, because later it becomes even more complicated because the cataract becomes harder and more difficult. So it is better that you do them earlier rather than later.
So Dr. Namrata, could you just explain again as to why putting a CTR is counterintuitive?
No, I'm not saying it is counterintuitive, but I'm saying that there are no studies to support that it is going to help, at least in the published literature, maybe in the personal...
published, but from a clinical perspective...
Yeah, unpublished, it may be there, but I have not come across, because we were doing a review article on colobomatous eyes, cataract and colobomatous eyes. So we did not come across, you know, any published studies of large cases.
I would tend to agree with Namrata, you know, except for the zonular defect in the area of the coloboma, the rest of the zonules are intact. So,
Can I add something, Chitra?
Get an additional support. There is no harm. Some people,
no harm.
So I couldn't agree with I agree 100% with what Ram said. I would go ahead with a phacoemulsification. I would not consider that because maybe I don't know how to do an SICS. But the point is that it is a localized defect. It is not a generalized weakness. And as Ram said, the proof in the pudding lies that you could easily get a capsulorhexis. If you had a generalized weakness, doing a capsulorhexis is a problem. If you can do a pre-chop with a that is the best. Normally, what is very, very important also to remember is that the parameters needs to be a little. That's about it. Apart from that, I would always put a CTR. And a capsular hook also helps in case there is any problem. You normally don't get a vitreous coming out. I have done lots and lots of these colobomatous eyes, and these behave in the same manner as anything else. One other thing too important is that if you put a lot of trypan blue, at times you lose the red glow, because the trypan blue tends to migrate backwards. So if required, use a trypan blue, but otherwise use minimal quantity and just see that you are not overdoing it, because it tends to obscure the good red glow that you have because of the posterior percolation from the defect area.
Mahipal, can I make a point, please?
You already made your point, Mohan.
Yes, sir. Yes, sir. You know, you can make your point, sir. No problem. You're a past president. I'm a president.
What I was trying to say is,
yes, Dr.
Yeah, I mean, what I was trying to say is, if there is a zonular, like Dr. Madhu did nothing, that should have given the rexis away. Now the rexis went away. Now he did a rexis and it was done well. Now why did the rexis go away? That is the point.
Did he
hit it with the chopper? What did he do? That is what I'm saying. If there's an inherent weakness in the capsule.
No, sir, I will not agree with you, sir.
Sir, I have never had.
No, I will not agree with you, sir. I want to stress that point. I fully agree with Ramurthy and Mahipal. It's only a localized one. I put the CTR at the beginning. I start with capsular hooks. I put 2 or 3 capsular hooks.
Only.
Okay, I don't put only one capsular hook. I put 2 or 3 so that there's equal stress on the attention on the back. And I've not seen a single case of a lens or a capsulorhexis or the anterior capsule getting split in these patients and able to go ahead with the phaco without any problem at all. Of course, in coloboma, as Namrata said, if you leave it for a long time, they end up in a very brown, black cataracts. Those cataracts, probably I will do SICS. But these cases, routine cases, grade 2, grade 3, I think this is the way to go. And there's no way, I think, I feel that it's only a localized just like a traumatic cataract it is. In a traumatic cataract, there's a localized zonulopathy. Similar to that, there is a localized zonulopathy in a lens coloboma or iris coloboma.
Is there
I think whether phaco or SICS, whatever is surgeon's comfort zone, whichever he is confident with, he can go ahead. By first case, what Madhu did, he saw what were the complications, what were the factors. So he to second eye, he took as SICS. So it's surgeon's comfort zone which should be taken into account,
I feel this,
and not the technique, whether it is phaco or SICS.
Amit, no, that is right. That is right. What I was saying, I feel that phaco has got enhanced safety in such a situation. There's a better intraoperative control than an SICS. You saw that SICS, when it tried to deliver the nucleus, how much of stress was there on the zonules. In phaco, it is not possible because everything is taken care in a phaco.
I disagree. Surgeon's choice.
Dr. Amit, I fully disagree. That carry home message should not be that you should go in for SICS because you had an extension. He had an extension. It was in the area of zonular weakness. He should have converted early. Phaco, by all means, if you are a phaco surgeon, by all means, definitely there is no to it. It is a definite yes with all the techniques, and we should definitely not emphasize that SICS is the preferred technique. If you
it is not preferred. Surgeon's choice. Whatever he is comfortable and confident, go ahead with that technique.
That is fine, but we cannot say what Rohit is saying that
I understand.
of SICS over phaco. There are enough and more advantages of phaco over SICS, specifically in a coloboma. So there should not be a wrong message taken home that if you are dealing with a colomatous eye, you should preferably switch over to SICS. I don't agree with that.
I don't agree with that.
I would 100% continue emulsification. Also, I am not comfortable with SICS, but I have not had problems. So getting from one particular case, and what Mohan has said, the whole thing, the way you are prolapsing and the way it is, there's more stress on the zonules than it would be with a phaco. With you have an endocapsular ring and you have capsular hooks. The things are very much under control.
Yeah.
So regarding the capsular hooks, if there is no phacodonesis at the time of doing the rexis, then would it be really required? If at all there is phacodonesis and you feel that there is a zonular weakness, only then would a capsular hook and a CTR would be required.
No, the capsular hook is just giving support to that area of weakness. Okay. That area of weakness, so that there is no stress on that capsule, that area.
I feel if there is a significant phacodonesis and you feel that there is instability, then I would go ahead and put a capsular hook or a CTR.
The basic concept is that when we are giving a support,
it gives us
capsular hooks.
It does not, because wherever there is a weakness, it tends to increase.
Yes.
So if you have a support, it will support. It would not allow it to extend. And like this is a hard cataract, I would put a capsular. If you are dealing with a softie, then it's very easy to do a hydrodissection. Like you are doing a posterior polar, you just scoop it out. And you don't put any stress on the zonules. So that way it would be all right. But
you mentioned about flax also. I think your voice broke in between. Did you mention about the use of flax also in these cases?
There's no issue in doing a flax because you are pre-chopping the nucleus.
Yes. Because I have used flax. I didn't hear you clearly at that time. Your voice cracked.
The only problem.
One last question.
Chitra, ophthalmic eye with a small eye with a coloboma, getting a good suction, I was not getting a good suction at all. Plus the OCT doesn't come. So if you are dealing with a 16-17 millimeter eye, neither does the OCT come. You have to try and fix all thing, and you don't get a good adequate suction because they don't have any suction ring or a LOI for such small eyes. That's all. But otherwise, phaco, you won't have a problem in capsular access. You don't have to be away from the zonular, and you have pre-chopped the nucleus, so you can easily remove it.
Can I ask one last
one question, Chitra? One question.
No more discussion. Go on.
No, Chitra, I mean, how was the first situation that Madhu was in? We dealt with the first situation where you have a capsular rexis tear and the nucleus going down. How would a surgeon retrieve this? Tell me.
You could look at this area of that rexis flap, whether it's everted or inverted, and you could, that was a very soft, not a dense nucleus. You could easily do a phacoemulsification, keeping an eye on that area of rexis weakness and get away with it. The last question which I want is, would you want to do a pupilloplasty in this particular case?
Oh.
Be one expert panel to comment, or it doesn't make sense, then we go on to our next speaker.
No, I don't think you should.
I don't do.
Because they already
I
have
just
an area of
want
fixation and they are fixating from
So
there.
we are not going to be discussing other things. There are too many speakers who need to be given
Sheetal has
justice.
been
Absolutely,
raising
I
her hand
agree
for
with
a very long time. Please give her a chance.
No, I just wanted to ask her the same thing because I've had decent experience in the coloboma, and I agree with you that they do not have generalized zonular weakness. And I've done pupilloplasty in number of cases, and what I realized is it doesn't make any difference. So that's the point I wanted to make.
Thanks a lot. That was good discussion. We go on to our next speaker.
Ma'am, I just want to congratulate Dr. Madhu on behalf of ARC and Bihar Ophthalmic Society. Dr. Madhu has done his post-graduation from Patna Medical College Hospital, same place from where you did your MBBS. So I want to congratulate him for the beautiful presentation he made.
Yes, yes. He's an amazing surgeon. We all know that. He showed a very good topic for discussion.